I would have been talking about it means that's the question. It's not. Well, it just that, you know, they penalize this. So now we go. You never know what happened. It's also not just here. This job is. If you get the right project, get that right away. So they give us the scale, you can take. So these things, yes, the good ones, right, was told. Of course, but they show us.
All right, thank you everyone for being here tonight. I'll just keep it short. We're here with Jamil Kendall, who is going to be giving us a presentation on hip and knee replacements. So I just want to thank Advocate for helping, get us presenters here to give us important, useful information. We've had this presentation before actually, and I've been there, and it was actually pretty worthwhile, and I learned something, and hopefully you guys learned something too. So without further ado, Jamil, if you want to come up.
Thank you so much.
All right, good evening, everyone. Thank you so much for being here. I really appreciate it. I have a little talk put together for you guys, mostly just focusing on some of the basics around hip and knee replacement, joint replacements. When do you try to get one? What do you look out for? What are the things to ask? I'll talk about some things specific to my practice, but I'll try to keep it general as well, just to give you some information, okay? As I'm talking, if you have questions, please feel free to interrupt, okay? And I can stop and explain anything, all right? Okay, we'll get started. So this is what we'll talk about. First, I'll give an overview of the anatomy of joints and joint pain and what that feels like. I'll talk about, what to expect at your initial assessment when you go to have these things checked out. What are the treatment options shy of surgery? What does surgery look like, and then what to expect afterwards in the perioperative time period and then after the surgery. Okay. So me, Jamil Kendall, I was born in the Virgin Islands. I did my undergraduate studies at Georgetown University. I went to medical school at Howard University, and then I did my residency, my orthopedic training in Oregon. Moved here to Chicago for fellowship at Rush, and then joined Parkview Orthopedics. I've been there for the past couple of years, focusing on hip and knee replacements. It's been really great. I'm over at Christ Hospital. I also go to Northwestern Palos Hospital and then a surgery center in the area. So a joint essentially is where one bone connects to another bone. And what a joint allows for is movement and shock absorption, basically. And so you have the bones, you have the cartilage at the end of the bone, you have different ligaments that connect the bones to each other, and then you have fluid between the joints that allow for them to move smoothly. So every joint is essentially made up the same way. There's some subtle differences. So the knee joint is on the left, all right? So you have the thigh bone at the top, the shin bone at the bottom, the kneecap in the middle. The darker blue is the meniscus, which is like a pillow almost between the two bones. The white is the cartilage, which is on the surface. That's the shock absorber. And then you have the pink ligaments, the ACL, MCL, and LCL are what you can see there. And then the hip joint is on the right. So that's shaped a little differently. It's a ball and socket joint, but you see the same white cartilage on the end of the ball. Okay, you have the femoral head, which is a ball of the joint. The acetabulum is the hip socket, and then the thigh bone is that part at the bottom there, okay? And then you have the capsule and ligaments around the hip. So before arthritis, or let's say early arthritis, sometimes patients will ask me, well, what do I do to stop it? There's not a ton to do to stop it. It is something that takes years and years, and it's developing, all of your life. But there are things to do to decrease the pain and make it more manageable. So those things I think are staying active, walking, bike riding, swimming. Those things are low impact on the joint. Some activities, running, those types of things are a little higher impact and can cause some joint degeneration. and keeping all the muscles around the joint strong really does help with joint pain, okay? Keeping a healthy weight is very helpful, all right? Every pound of in the body is 4 pounds on the joints, okay? So small changes in weight can really have a big impact on how your joints feel, okay? And then eating healthy foods low in inflammation and low in fats and cholesterol and things that are bad for you, that does help with just overall inflammation in the body and how your joints feel. So you have a knee pain, hip pain, and you don't know what's going on. Some things that I think tend to point more towards arthritis type pain versus other type of pain. The pain comes and goes. Maybe it hurts for a week, it hurts for 2 weeks. You didn't do anything. It just came up out of nowhere, and then it goes away. You take some Advil, and then after a couple of weeks, it's gone, and you kind of get back to your normal life. No injury. You didn't hurt yourself. Um, Hip pain actually usually is more groin pain, as opposed to pain in the buttocks or pain on the side. That kind of points more to the hip joint as opposed to other things like your back and stuff like that can cause pain in that area. Pain in the knee can be on the inside of the knee, the front of the knee, the outside of the knee. Sometimes people have difficulty with stairs, putting the shoes on, pain at night, using over-the-counter pain medications more and more. Big thing for me is when people are avoiding to do certain activities, making decisions because of the pain that they're having, because they just start to, they're causing more and more issues. Now, you're feeling these types of things, and this is what's happening in the joint. Okay, so arthritis is essentially a disease of the cartilage. The cartilage at the end of the bone, the cushion is wearing away. The bone underneath is where all the nerve endings are. And so that's getting more and more pressure because it's not being protected, okay? And so you see here on the left, in the knee joint, that cartilage, that nice shiny white cartilage we had is wearing away. The bone underneath is starting to be exposed. You develop these bone spurs and all these things that happen during the arthritic process. And same thing on the picture on the right with the hip. Cartilage wears away, bone is exposed. Now you have that bone grinding on that bone, which is really, really painful. So there are a few different things that cause pain in the joints, and all are kind of related to arthritis. So you have osteoarthritis is your general arthritis that most people experience, okay? Long-term degenerative disease from years of activity that cause the joints to wear away. Some people have things like rheumatoid arthritis, psoriasis can cause arthritis. Oh, did not mean to do that. Different diseases that can also cause you to have arthritis in your body. Sometimes an injury can cause arthritis in the joint, like a broken bone near a joint can cause you to develop arthritis. Some people get something called avascular necrosis that usually happens in the hips, where you have a blood flow issue to the ball of the hip, and that can cause degeneration and pain. Then you have some soft tissue injuries like meniscus tears, labral tear in the hips. They're similar types of structures, which over time, because if let's say the meniscus is not working properly, you don't have that that pillow between the joints, it's not protecting it as well as it should. That can also cause the joint to start to degenerate faster. Okay, and then some people are born with different shapes to their joints that cause them to wear away faster than others. So when you go to the doctor for that first evaluation, all orthopedic surgeons will want to, or any person wanting to evaluate a joint, they're going to want to look at an image. So they'll get an X-ray first, usually. Sometimes we'll get an MRI, depending on what we're worried about. If we think there might be a soft tissue component to what's going on in your knee or your hip, we'll get an MRI to check. Some of those things like the avascular necrosis and some of that blood flow issue, we can see that better on MRI than on X-ray, especially if it's early. We'll ask you questions. How long have you been having these symptoms? Have you had any issues in the joint before? Have you had any sort of treatments? What medical problems do you have? Things that can, point us in a certain direction. And then we'll do an exam. We'll see, where does it hurt? What kind of motion do you have? Sometimes in very severe arthritis, you can lose the range of motion in the joint. And then is there instability? Is there any concern that the ligaments in the knee or the hip are not working like they usually do? There are a few non-surgical options to treating arthritis. Physical therapy is a big one. Not all patients like doing physical therapy, but it is something that I've seen work. And I think for the right amount of arthritis and the right patient, I think it's something that's helpful. Really strengthening the muscles around the joints really can help with how you perceive the pain in the joint. Pain medications, usually starting with over-the-counter medications. Anti-inflammatories like ibuprofen, naproxen, those work the best. There are a lot of people who can't take those if they're on blood thinners and things like that. So Tylenol is a good alternative. And then sometimes we will prescribe prescription medications. So there are some prescription arthritis medications that are similar to ibuprofen but work a little stronger that we'll typically prescribe. There are different types of injections. We more do injections in the knee than into the hip. But we can do injections in the hip on occasion, once again, for the right patients, right situations. There are the cortisone injections and then gel injections. Those are the main two that we do. Cortisone benefit is we've been doing it for a very, very long time. We know that it works. The downside is it tends not to work as long in a lot of patients. I find that I have a lot of people who have a great response for a month, 2 months, and then the pain comes back. And it can spike your blood sugar for patients that have diabetes. So I tend to avoid it in those patients. The gel injections, what they do is they help the knee re-lubricate itself, essentially. So it doesn't grow back the cartilage or anything like that, but it does help the knee to work a little more normally by helping it to be lubricated. Those are typically multiple injections. So sometimes it's 3 injections in a row. You do it once a week for 3 weeks. So that can be a little inconvenient depending on patients' schedules and stuff like that. But they do tend to work a little longer, more like 6 months as opposed to the 3 months that you get from the cortisone. Typically, I do not do those in the hip. There's not really good data for those types of injections in the hip. So if I do injections in the hip, it's usually a cortisone injection. Okay. There are other things like PRP is where they take your blood and spin it down. And I know they have like QC Kinetics. They do advertisements for those things. I think some of those things are a little bit more experimental. They probably work. I don't know if they work much better than the other things that we have. But I think patients really seeking to avoid surgery, they are options to try. Weight loss can be a helpful tool. Bracing can sometimes help alleviate the pain, just giving some more stability to the joint, specifically for the knees. And then, going to a cane or walker when the pain becomes very severe. When is it time to start considering surgery? So I like to exhaust non-operative treatment. So we've tried injections, we've done therapy, we've tried medications, we've tried all these things, we're running out of options. Your quality of life is being impacted. And that is for the person in their 50s who was going to the gym every day and, playing pickleball and now is not able to do those things. And for the person who, is in their 80s and just wants to be able to go to the store and go to church and is not being able to do those things. I think whatever your quality of life is and whatever the things that you do that you enjoy, I think really the goal is maintaining those things. Okay. And then the third thing is patients have to be ready physically and mentally to make the jump. It is surgery. It's routine for me, but it's not routine for patients. And so undergoing it is a big undertaking. And so being ready to do what that requires, I think is really important. And so in a hip replacement, this is what we do. Essentially, we remove that diseased ball and we clean out the arthritis in the cup. And we put a metal piece that goes inside the thigh bone. We put a ceramic ball on that, and then a plastic piece and metal piece that go inside the cup. And those things work together to then act as your new hip joint, okay? Now, one big thing that, patients are asking more and more about is which way are you doing the surgery from? Are you doing it from the front or from the side? Okay, so the front would be the anterior approach, and the side would be the posterior approach. The difference being, how are you manipulating the tissue to get into the hip joint? All right, and really the question is which of these approaches are better? I think they're both really good. Okay. The anterior approach, the benefit of it is you go between the muscles instead of going through the muscles, which in theory should help with earlier recovery and all those things. And there should be a lower risk of dislocating the hip after surgery. The posterior approach is a little bit more of an expanded type approach where you can really do everything from it. You can get into any sort of issue and really be fine. And most people have done more of those in their time. And it's something that we've always done for a long time. I think for me, I really do enjoy the anterior approach. I like that patients do seem to recover quicker from it. There are no precautions after surgery that you can't cross your legs and those types of things, which I think can be a little stressful for patients, just worried that they might do something wrong. And then during the surgery, there's things that I can do. I can use X-ray and these things to make sure I'm putting everything exactly where I want to put it. Now, on occasion, I do the posterior approach. My approach to that is that I do a very small incision, and so my incisions from either approach is about the same size, but it allows me a little bit more flexibility for really complex issues. Let's say someone had a previous surgery, their anatomy is not normal, those types of things. So those are the patients that I tend to stray towards that for. There's slightly increased risk of wound complications coming from the front, and so for those patients, I'll do it from the side for my higher BMI patients. But what I found is, thankfully, patients do very well from both. Patients really, really do well from the hip replacements. Yes, go ahead.
Birmingham resurfacing and hip replacement surgery.
Yeah, so I do not do hip resurfacings. And if you're asking for you.
No, I already had it.
Oh, you had
20
one.
years ago.
I was about to say, what we found is we don't really do them, especially in women. They're contraindicated in women now, and I think the thing with surgery, we learn things as we do things more and more. So I don't do hip resurfacings. And the reason being is, yeah, I mean,
Israel was bad.
they work for the right patients. I think we still, there are people who still do them for very young patients, especially athletes, especially athletes. But the materials for standard hip replacements now are just so good that we're not as concerned about the material, things wearing out, the plastic wearing out and those types of things. And like for me, I let my patients, if someone they ran and did things on their joint before, I let them do the same things afterwards. So I think we're a little more aggressive with what we let patients do after surgery. So there are some people in the area that still do that, but not,
Really?
yeah, not something that I do. Yeah.
The only thing I can't do is downhill snow ski, so I was told. But I mean, it went right through muscle, the upside down J through the back, down the leg.
It's a big incision.
It is, it's horrible.
It's a huge incision.
I'm surprised I thought they took it off.
Yeah, no, it's contraindicated in women. There are still a select few people in the country still doing them. They're not. It's not a lot. It's not a lot of people. So if there are a few people, I know there's someone at Rush that does them. I think that's the only person I know in Chicago that's doing them. There might be one other person.
Yeah, I had mine done at Advocate Christ.
Okay. Yeah. I don't. No one there is still doing it.
Oh, good.
Yeah.
Thank you.
Of course, no problem. Now for a knee replacement, similar idea. We remove the cartilage, but instead of removing a big chunk of bone like we do in the hip replacement, in the knee replacement, we're basically resurfacing the ends of the joint. So we remove the end of the thigh bone and just where that cartilage is, and we put a metal cap on it. We remove just the top of the shin bone and put a metal piece that sits right inside of it, and then we put a high grade piece of plastic that goes in the middle. Okay, and then we put if there's damage to the kneecap, we put a piece of metal, a piece of plastic that goes on the undersurface of the kneecap, and this allows the knee to once again move nice and smoothly. We do remove the ACL because you have to. There's no knee replacement where you keep the ACL in place. But the way I do it, I keep all the other ligaments in the knee to help the knee feel as natural as possible.
Do you use the same knee size for every person?
No.
Do you use specific
We use
size?
specific sizes. So all the companies have done all this extensive research to see what are the, based on the population, what are the sizes that we need to match most people. And then we have tools during the surgery that we match what's closest to your anatomy.
Thank you.
And of course.
Mhm. I've heard of patients who have some level of allergy to the metal. Is that an assessment that's done prior to surgery or what?
So there is some stuff about metal allergy and nickel allergies and these things. And there are some implants that are nickel free. My read of the data is that it's not clear what the true allergy is. You know what I mean? And so for most patients, if someone does not document, hey, I have an allergy, I've had allergy to different types of metals and stuff like that in the past. I don't know many people who routinely get who do metal sensitivity testing beforehand. Now, if someone was to say, hey, yeah, I have had issues, with different types of metals, I've had rashes and stuff from jewelry. I would just use an implant without any nickel. It's usually the nickel in the implant if there is an issue there, but it's very rare, and it becomes one of those diagnoses of exclusion where you test every single thing and you're like, well, maybe this is what it is. A lot of the companies make an implant without nickel if there is some sort of allergy documented. But I do find that it's very rare. When I was in fellowship, one of the guys there, he's kind of the leader in kind of a lot of that research. And talking to him, he's like, after all these years of studying it, he's like, it's just so hard to really prove sometimes that it is the implant, that is causing the issue.
Next question, Ali, what would be the effect if somebody was allergic to that? Would it ruin the whole procedure? Or?
Well, what ends up happening, those patients, they usually complain of some, pain and discomfort, and it just never feels right. Which because of that, it's so hard to really tease out, and you can do different types of, there's tests that you can do to check, but that's really what ends up happening. It's just that they're not happy. But it's not like they don't get infected or any of those types of things. But they're just very, very unhappy. So it's rare. I've had one patient that I've treated that had a previously documented metal allergy, and but in the hip replacements, actually the implants don't have any nickel in them anyway, so it really wasn't an issue. But yeah, it's more of a unhappiness after surgery thing. Yeah, of course. All right. So outside of the standard hip replacement and total knee replacement, there is a partial knee replacement that we can sometimes do for the right patient. And the knee has three compartments. There's the inside of the knee, which is the medial compartment. The outside is the lateral compartment. And behind the kneecap, we call that the patellofemoral joint. And in patients with very isolated arthritis, you can treat one of those compartments only. Oh, I moved forward. You can treat one of the compartments only, okay? And I really like this surgery, you know, if you find it in the right patient, because it's less surgery, the incision is smaller, you're doing less work, and the recovery is much quicker. Those patients tend to be very, very happy. But you have to do it for the right patient. Okay? Of course.
What is the right?
The right patient. The right patient is someone in my hands who on their x-ray they have arthritis only in one spot. Everywhere else looks completely normal. And when I do an exam on them, they only have pain in that one spot. A lot of times I will see patients who their x-rays look like it's in one place, but they have pain in other places. And I worry that, you know, 2 years down the line, 3 years down the line, 5 years down the line, they start having issues somewhere else. And that's the biggest issue with this surgery is if you don't pick the right patients, they develop arthritis. That's the biggest risk. You develop arthritis somewhere else that's symptomatic. And at that time, you usually have to convert to a full knee replacement at that time. But that's the thing is really being, at least for me, really being picky about.
Well, what's the
who you
difference
do it on.
between the recovery from a total hip knee to a partial?
Yeah, I found that my patients that have a partial knee replacement, at that first visit,
Like 2 weeks post-op?
yeah, I see my patients at 3 weeks post-op. At 3 weeks post-op, they're walking without a cane or anything like that. They have pretty minimal pain. And they're, you know, they're
That's
not,
with partial.
and that's with the partial. With the full knee replacement, most patients at that first visit, they're walking with a cane, some with a walker. And they may be tapering down on their pain medication, but they're still stiff. You know, the partial replacement, I mean, they're at that first visit, their motion is pretty much back to normal. So it is a quicker recovery, but it's a lot less surgery. And you don't remove the ACL like I was talking about for the totals, and so the knee feels a little bit more normal.
What function does that ACL have again?
It just in the full knee replacement, it really doesn't, removing it does not affect the function of the knee. But what it does is, you know, everyone has you have all these sensory things in the different ligaments and stuff like that. So the more that you leave alone, the more normal the knee feels. And so with the partials, because you can leave that alone, the knee just feels more like your normal knee. That's really what it is. But functionally,
Bilateral replacement at the same time?
I do not do that. My reasoning for that is I think yes, it is one anesthetic and you do everything at the same time. I think the recovery is more than 2 times as bad. For in the long run, really no benefit. And most of these we do with a spinal anesthetic. The anesthesia part is very safe, and so I don't think it's worth it. I think there are situations where it can be considered, but mostly, you know, someone who, based on their job, you know, is unable to get the time off or, you know, something like that, you know. But outside of that, I would recommend against it.
And you said spinal anesthetic plus, Jenna?
No, so my preference for anesthesia is a spinal anesthetic, which means they put medicine in your back, makes you numb from the waist down, and they give you very light medicine to put you to sleep. So you don't remember any of the surgery, but it allows patients to wake up really quickly. You don't have all the grogginess from a general anesthetic. You don't have all the nausea and stuff from, you know, all the strong medications they give you. And then the spinal wears off so that you can get up and start mobilizing kind of right after the surgery. So that's typically what I do. Of course, some patients, either they've had issues of back problems in the past or they've had spinals in the past and they didn't have a good experience. Or if for some medical reason a general anesthetic is better, then we'll do a general. But for the most part, that's the what I prefer. Yeah. Okay. So what I do in general is called minimally invasive surgery. For me, what that means is My incisions, I try to keep smaller than the standard incision. That damages less tissue, less pain after surgery, less blood loss. I also do different techniques to avoid cutting the tendons and like we were talking about the different ligaments in the joints. And so that's why I like the anterior approach because I don't have to cut any of the muscle. I can go between the muscles, move them out of my way, and then everything goes back exactly where it was before. And in the knee, instead of cutting through the big tendon, the quadriceps tendon, I go to the side near the muscle. So I leave the tendon alone. This allows for early range of motion and function. And I've found that it's been really good for my patients. Do you have a question?
Yeah, do you find that people, there are patients who need knee replacement, they begin to have problems with their ankles as well?
Sometimes I actually do find that patients, or what I think it is, it depends on the patient. What I think it is, sometimes patients, especially if their arthritis is causing more deformity in the knee, like they're becoming more bowed or more knock-kneed, it puts a lot of stress on their ankles and their gait becomes abnormal. So I actually have seen that. Sometimes I also see patients with a lot of swelling in the knee. Sometimes they will get a lot of swelling down in their ankles too. Yeah. Okay, robotics. Now, I do not use robotics in my practice. Well, unless for, kind of extenuating circumstances. But I do think it's important for you guys to know about it, to ask about it, and to, also do your research and see if it's something that you would want to seek. Okay. Basically, what robotics in joint replacement surgery, when we talk about robotics, the different types of robots, they are a tool that we can use for planning the surgery and for positioning the surgery. Okay, so usually you'll need to get either an x-ray or sometimes you need to get a CAT scan before surgery to help with the planning. Sometimes there's a cost associated with that, depending on the surgeon and the platform that they're using. The surgeon is the one doing the surgery and kind of making the plan and guiding everything. Okay. It can help with accuracy. So far, we haven't found much of a difference in the outcomes after surgery. I think, what the data does show, I think if you don't do a ton of joint replacements, I think it helps to get rid of the outliers. And so if you do one here or there, I do think it's a really, really good tool to kind of bring you to the mean all the time. I think for people who do a lot of joint replacements, I think the outliers just kind of work themselves out for the most part. Usually you need to do a slightly bigger incision because there's little pins and stuff that you need to use, or you need to make extra incisions just to put the cameras and stuff in. Okay. And I do think for like complex surgery or for like, let's say for a knee replacement, if you have a rod in your femur because you broke your femur, I think there's a really good time to use robotics because it does help to, kind of mitigate some of those issues that could cause complexity wise. So we're talking about the anesthetic. So usually we do it with a spinal and a twilight. Helps you to wake up faster and everything like that after surgery. Most patients can go home the same day. Exceptions, older patients, patients with any severe cardiac issues that you need to monitor overnight, those patients need to stay. And then patients, if you don't have any help at home, you live at home by yourself, there's no one who can come by and be with you, at least for the night after surgery and stuff, then it's usually safer to just stay overnight so we can monitor everything and then have you go home the next day. Okay. For everyone, up and walking the same day, okay? Physical therapy, working with you before you leave the facility, whether it's that day or the next day. For me, I like to have physical therapy come to the house the day after to start getting working with you, and then using a walker to begin with, and then over the next few weeks, weaning yourself off. Okay, driving. Somewhere between 2 to 6 weeks, it depends on the surgeon. For me, I'm okay with patients driving after 2 weeks. And then I leave it up to the patient when they feel comfortable. But I would say most people somewhere between 2 to 4 weeks, 2 to 6 weeks is what they would ask you to how long they would ask you to limit. Around 6 to 8 weeks is when most people are okay with you increasing activities. Some things like so a lot of my patients they golf. Around 8 weeks is when I'll let people start, just like hitting a ball, but not necessarily doing, actually going out and playing around a golf. That I usually try to wait closer to 3 to 4 months. What we can see sometimes if you do too much too early, especially on a knee replacement, I've seen people have little setbacks where they get sore and then it takes a while to kind of overcome that. Okay. Um, as far as being off of work, on average, I would say my recommendation is somewhere between 6 and 12 weeks. All right. People who do very labor intensive, demanding jobs, I try to ask them to do 3 months. Sometimes people can only do 8 weeks, and we work within what people can do. But I try to get people who have very labor intensive jobs to do about 3 months. People who work from home, very sedentary jobs, sometimes can go back as early as 4 weeks, but I try to get people to take at least 6 weeks. It gives a little bit of a buffer. Sometimes people recover very fast, sometimes people have a slightly slower recovery than we expect. Um, at around that 6 to 8 week mark, I think people are about 75% recovered, 80% recovered, especially in the knees. In the hips, people are doing pretty good at that point. And the hip recovery does really tend to be a little easier than the knee recovery. But around that 6 to 8 week mark, I expect patients to be walking, most patients without any sort of assistive devices, doing their normal day-to-day activities, going to the grocery store, doing stuff in the house, driving, and all those things. But maybe not back to the gym, maybe not, going on 2 mile walks and those types of things yet. Okay. Not really taking much pain medication, taking Tylenol or ibuprofen on occasion, if anything. Okay. And then yes, knee replacement recovery, it can be harder. That is very therapy dependent. That first 6 to 8 weeks is when we really want to regain all of our motion back in the knee. Okay. The majority of the motion is going to come in that first time period. All right. So getting moving early, for my patients, I want people by the time I see them for their first visit, getting as almost all the way straight and then bending to at least 90 degrees. And that's usually a good sign that we're gonna be happy at the end of everything. Contraindications to surgery. So anyone with an active infection, uncontrolled medical issues, specifically diabetes, if their blood sugars are running too high, their A1C is too high, or if they have cardiac issues that need to be addressed. Vascular issues, if we're worried at all about healing a wound because there's poor circulation. Malnutrition, that's something that we check to make sure that once again, you're going to heal properly from the surgery. If someone is not able to do the physical therapy after surgery, whether it be, based on their health condition, they're not, strong enough to participate or for whatever reason, then, I worry that even if we do the surgery, you're not going to be able to get the benefit of it afterwards. Active smoking for me is not something that I move forward with for my patients. Once again, just a risk of infection with an active smoker. And then this one's a little bit more controversial. In my practice, I don't have a strict cutoff for BMI. I think BMI is a tough thing because while we want patients to lose weight, have healthy, a healthy weight and all those things, I also realize that if your joints hurt and you're not able to be active, then you're not able to do the exercise and you're just in a cycle and, you're trying to get out of this cycle. For me, a patient with a high BMI that's pretty healthy is fairly low risk. And that's what the data shows too. And so I don't use that as a one thing to consider. I consider it as part of the entire package. Now, some people though do have strict cutoffs. Some people is 35, Some surgeons, their cutoff is 40. So it's just something to consider as you go and talk to different people. It may be, a qualification that they have before moving forward. All right, so a few questions that people commonly have. So am I too young for a joint replacement? We are operating on patients for joint replacements at younger and younger ages. All right. I'd say 5 to 10 years. Most people wouldn't do a knee replacement on someone that was younger than, let's say, 55. I think that's certainly shifting, okay, where we're doing them in people in their, mid 40s if necessary. Once again, the implants are the quality of the materials is just improving, and we're trusting the materials to last longer. And hip replacements, we've always done them on people who are fairly young, and we're just doing that more confidently. Now, if you can avoid it, of course, yes, try to avoid it. But I think for the right patient, telling someone with bone-on-bone arthritis that you have to wait 5 years, I just don't, I don't agree with that. Now, too old for a joint replacement. That one's also, we're shifting how we think about it. If someone is, a patient I operated on 2 weeks ago, she's 92, she lives at home alone, she's active, she had a knee replacement 3 years ago, she's bone-on-bone arthritis, and I think that's a perfect person for a knee replacement. I don't agree with the idea that based on age, patients should be in pain and just stop doing things. As long as they're healthy and can participate in the therapy and do these things. And so really, how I like to think about this whole thing is you take every patient as an individual as opposed to kind of blanketed statements for everyone. How long will it last? The data that we have right now is saying the new plastic that we've been using for the past 15 to 20 years is not wearing out at all for about 23 years. So almost 25 years of like no wear in these patients. And so realistically, I think, it's fair to say we should expect these, the plastic to last at least 30 years. I think if I operated on a patient in their late 50s, I expect this to last the rest of their lives, especially someone once you get into your 60s and 70s. This should be the last surgery that you get, barring some other sort of complication. Setting off metal detectors sometimes. You just let the TSA people know. They're so used to it that they just put you in the other machine. The implants, so the hip implants are made out of titanium for the most part, and then high grade plastic, and then ceramic. Most people are doing ceramic. Some people do a metal ball still. And then the knees, most of them are made out of cobalt chrome and titanium, combination of the two. And then will I be able to still be active? So I let patients do anything that they were doing before that it's okay for them to do. If someone asks me, can I run? And I ask them when's the last time they ran, and they say it's been 10 years, well, I don't know. But if they ran, 2-3 months ago, then sure. But the goal of this surgery, the goal of all of this, whether it's injection, surgery, whatever you're doing, the goal is to continue to be active and do all the stuff you're doing before.
But does that wear it out faster if you go running?
That is a good question. And the short answer is yes. But that is a conversation that I have. Okay. So, if someone is a runner and they want to run, and I think risk benefit, the risk is that the plastic might wear out. The procedure to treat a worn out plastic is fairly straightforward. It is a surgery, but you go in, you take the plastic that's in there out, and I know I'm making it sound very simple and, it may sound like I'm minimizing it, but it can be a very straightforward thing where you take it out and you put in a new one. And so if that is the thing that gives this person joy, I think it's worthwhile. All right, so a good candidate for a joint replacement. They're healthy enough for surgery. They're motivated and committed for the recovery process and all that it entails. Their expectations are reasonable. Okay. They have a good support system around them, and they've tried some sort of non-operative treatment. You know, there are definitely patients that come into my office and like they have never had anything done at all, but they are completely bone on bone, and I don't think it's necessarily worthwhile to start doing injections and stuff because you know the joint is pretty much shot already. Well, for the majority of people, you know, when they're first seeking some sort of treatment, there's some stuff that we can try. Okay, so how do you find a surgeon when you're at this stage? Everyone has a profile online. Everyone has a website. Some people have their own website aside from their practice's website. I would look them up, read about how they do things, look at reviews, you know, see what other patients kind of experience they've had with them. Word of mouth is important. Talk to people that you know who've been through this. See who they've liked, see who they haven't liked. Your PCP will have some relationships with different surgeons in the area. That can be a good resource. I would say to find someone that does a lot of joint replacements. Okay. We're seeing it less and less, and this is not to, you know, say anything about people who are more generalist, but I do think that there is a benefit to doing a lot of these surgeries. I think that the data shows that if you do above a certain amount of these a year, your complications decrease. You know, a lot of the negatives that can come with a joint replacement do go down the more that you do. Okay. And then find someone that you trust and feel comfortable with, because this is now a relationship that you've entered in for the rest of your life, really. Okay. Anything goes wrong with this joint, you're going to end up going back to the same person. And so it should be somebody that you feel like you trust and you can be comfortable and ask questions to and all these things. Okay. Important things to ask. I would ask them about what their treatment options are. You know, maybe be wary of someone who you may feel is like pushing you in a direction that you know, or not answering questions that you have about it. And then what their post-operative program is like, and you know, see if it kind of aligns with what you would, you know, what you would want. Okay. And completely fine to get a second opinion. All right. I've had patients come to me for a second opinion just to make sure I agreed with the person that they already talked to, that they liked, but they just weren't sure because they just wanted to double check. All right. It's completely fine. I think every surgeon expects that it will happen. Okay. Don't feel like you're stuck with someone that you might want to talk to someone else. All right. And just to wrap up, worsening pain in the groin or knees, that's a sign to at least see your primary, see an orthopedic surgeon. If you have an insurance plan, that doesn't need you to have a referral first. Get an x-ray, see what's going on. You know, try the non-operative stuff, but know that, you know, as things are worsening, you may need to consider surgery. There are multiple ways to approach, you know, these surgeries. A lot of them do really, really well. There are some benefits to some different nuanced things. And then find someone that you trust with a good reputation. Okay. And you do not have to live in pain. Okay. You don't need to become painful and give up things and, you know, have your knees and your hips kind of run your life. All right. Joint replacement, it's safe, it's effective, and it can really change the right patient's life. Okay, good. That's all I have. What questions can I answer?
For knee replacement, are there certain activities that should be avoided? What can you do?
I honestly, I truly believe, I think you can do whatever things that you want to try. The things that can, to your question before, the things that can wear out a knee faster, high impact stuff, running, skiing, basketball. Those are the big things. Even like tennis may be higher impact. You know, a lot of patients are playing pickleball. That's fairly, you're not moving that much. So it's not really that much impact on your joints. Walking, people can walk to their heart's content. Hiking is completely fine. swimming, those types of activities. You know, there are a lot of patients who, now I have some patients who really, you know, beat up on their joints. And it's not always like these high impact stuff, but they're just very, very active and do things. And, you know, knowing that the goal is that you forget that you had a joint replacement. That's like the ultimate goal, you know. That doesn't always happen. But because it's not your joint, there may be some things that just don't feel comfortable. Kneeling is a big one. Okay. You can kneel after a knee replacement, but the incision, it always, you know, it feels a little funny. Some people can do it, some people can't. And so it's not that you're gonna hurt the knee, so you can do it. So you can do it, but you may not be able to do it as easily as you did before. You know, you may need to wear knee pads and stuff like that, just because it's uncomfortable. So I really try not to say, hey, here are the things that you can never do. But you know, my point about realistic expectations as well is, you know, if there are things that you were having a lot of trouble with before, there are some things that are easier to get back to and some things that are not as easy.
Question from the chat was, does generalized anxiety disorder aggravate arthritis?
I have not seen any data around anxiety affecting arthritis. What I have seen is patients with anxiety disorder having you know, making sure that that's addressed around the surgery time, just to kind of maximize recovery and how patients proceed throughout recovery. But a direct link to arthritis, I've not seen. I'm not sure about that. I have to look into that.
Would you have access to my MRI and my X-rays and everything, or you have to start?
So what I think the best way to go about it, if it was all done through the advocate system, typically, especially if it was done at Christ, I can see all that stuff. And so what we typically do is have you make an appointment to see me, and if things have been done before that I have access to, or if you have it, really bring a disc is the easiest way, and then we can upload it to our system, and then we can start from fresh and have a conversation about that.
And then, therapy, like physical therapy, if you can't drive, like. How many days a week am I expecting?
Yeah, so
To take these therapy?
that's a good question. So a big reason why I do therapy that comes to the house for the first few weeks is that same issue.
Okay.
That way, you know, people, especially people who live by themselves, they don't have to worry about transportation to and from physical therapy.
Yeah.
So I have therapists and I have therapists and a nurse that come to the house for the first 2 to 3 weeks. And then around that that first visit in the office, most people are close to being ready to drive, you know, and that's a good transition period to then go into outpatient therapy.
Oh.
And what I see is, you know, for patients who have their left knee or their left hip done, that 2-week mark, they're pretty much ready to go. People are doing their right side, they're a little bit more hesitant. Not that I changed my recommendation, but you know, because you can drive at 2 weeks if you feel comfortable slamming on the brakes in an emergency. And so it's that little bit of hesitation that kind of causes people to wait a little longer. If you had a question.
So to answer, how many replacements have you done?
Have I done? Last year I did about 200 cases. And so and then when I was in training, we did a lot. The numbers were even higher than that. Yeah.
I have a lot of different situations I have both of my knees done.
Mm-hmm.
Great.
Yeah.
Can't tell the difference. Been 6 years. And my wife had it done, same doctor. And didn't work out. It said it was done perfectly. What option? Yes. To benefit about it.
Yeah. That's so hard because every knee is a different, and you know, every patient's different and one of the hard things about surgery is you feel like you did a great job and, really what all that matters is how the patient does afterwards. I would do, I don't know what kind of workup they've done. But sometimes there's little things, sometimes the implants loosen from the bone, sometimes there's subtle things. And, I would just do an extensive workup to try to figure out what is it that's causing the knee not to work right, Sometimes it's having a fresh set of eyes look at it.
Get some of the people, if not you, but somebody else did something.
Yeah.
Get that and you take those people through.
I do, because honestly, it can be harder, I think, to be critical of your own work and say that you made a mistake. Not that this person made a mistake, but sometimes it just takes a fresh set of eyes to see, hey, do you see anything that I'm not seeing? I've sent patients to get second opinions, to other people as well. But that's what I would do. And then they'll start from fresh. And then they don't have the baggage of like I did a good job in the back of their head. They're just like, let's figure out what's wrong.
Okay.
Yeah, good question.
What do you know about these so-called recovery supplements?
Oh, like the protein shake type stuff.
Or those types of things where doctors are basically soliciting these recovery supplements to say that will help you recover quickly.
Yeah, so there are more and more people. I don't know if more and more people. There are people who kind of have this as part of their recovery kind of package. I use one for some, or I offer one that's optional for patients to use. And essentially what it is, it's like a program, a perioperative program that's supposed to make sure you're getting all the nutrients that you need. And once again, just trying to address that, like, I was talking about malnutrition before, and kind of just making sure patients are getting all the nutrients that they need. Because not everyone is, eating that healthy, that balanced diet, in the surgical, around the surgery, especially if you're, it's one less thing to think about too, right? If you just had surgery, depending on what your resources are like or what your support system is like. So, I know there are a few places using it here in the city. It's something that I offer. I think the data behind it is pretty good, just about the, what kind of malnutrition we see in patients in the perioperative area. But that's basically what yeah.
Have they made a difference?
The patients that use it seem to like having it. And then sometimes I have patients, at least, for my practice, I have patients who will not use it, but will say, I like the idea of it, and they'll get something on their own, or they might be doing something like that already. And so, I'd say, if I'm being honest with you, I don't track the use closely enough because I don't want patients to feel like they're getting forced into it. So it's there if they want it, and if they use it, great for them. And if they don't, because it is a cost, it's an out-of-pocket cost for them. So I really don't want people to feel like they're being pressured into having to, pay for additional things in an already expensive process.
What therapy is for knee replacement?
So my program is home therapy, followed by, I usually do a 6-week post like outpatient therapy order. Some patients stop shy of that. So I'll say most people end up doing about 6 weeks or about 8 weeks of therapy. Some people do maybe 6. Some people extend it after that 8 weeks. The recovery is all based on how well you're doing, and so the goals that I have for patients and the goals that the therapists have as well, getting back to your full range of motion, okay? And then they do different things to see how your strength is doing and to make sure that your strength is coming along well. One issue we run into sometimes is, therapy also is depending on your insurance, therapy can become expensive. And so, I have patients who will, shorten their therapy just because, it's hard to access and, they're coming out of pocket for different sessions and stuff. So, as in patients who can be diligent with their therapy at home, I think that's okay, even if you stop it short, at least as long as you continue until we meet the goals.
So after your therapy, I had a knee replacement as well 3 months ago. Very difficult recovery for me. I don't think I'm ever gonna do the right thing, but in any case, what my question's gonna be.
Is it after the therapy?
You have to continue to do something every single day? Cause I'm having a hard time getting out of bed in the morning. I gotta do this, stretch out my.
Because it's still stiff, but you're 3 months out.
Yeah,
I think that's normal at this stage. To still have some stiffness in the knee, I think that's still pretty normal. And I think what you'll find is like 6 to 12 months is like for the recovery is a very real thing. And like I just saw someone today who's a year out, and he was on pain meds for a few years. He had a lot of different issues. I just saw him today. Very nice guy. And the last time I saw him, he was kind of in because I see patients at 3 months, and he's like, it's okay. I'm still taking the pain medication. I'm taking the same amount I was taking before surgery, but like it's still sore when I get up, and I'm still, I'm about to stop therapy. And I saw him today, and he's like, I've been off of the pain meds. I've had no pain, but he said he got off pain meds, 5 months ago. So it took him to be 6 months out from surgery, 7 months before he's able to completely get off all the pain meds, and that's, it really does take a while for some of the inflammation to go down, and some of or patients will tell me they have tightness, at that 3 month mark. They're like, it just still feels tight. This takes a little bit for that to really ease up. So it's hard to, I think if you're still having some of that at this point, first of all, I don't think it's so abnormal. I think it should continue to get better, and I would keep working it though. I would keep just try to loosen it up when you get up, and keep doing the exercises at home. I would keep doing it. Yeah, but it can take a while. It can be frustrating. Patients are sometimes frustrated because it's just not as quick as they want it to be. But yeah, unfortunately.
What kind of exercises you do with those?
In therapy, so they'll do a lot of quadriceps strengthening exercises. They'll do a lot of stuff where they're pushing your knee and making it bend. And then as you're getting your strength back, they'll do some balance exercises where you're kind of working on, you're getting your gait normal. Some people they've been walking abnormally for a long time. They end up focusing a lot on just gait, walking and putting your foot flat down when you walk, because if your knee doesn't go straight, you end up kind of walking like this. People walk with a limp. So they work on a lot of things other than just strengthening the leg. Yeah.
Could that be, the hip and the knee, could it be the same as the shoulder?
In what way?
Like, surgery and things like that.
Like in the what the recovery is like?
Yeah.
The hip recovery is easier than the shoulder and the knee. The shoulder might be worse than all of them. Shoulder recovery is tough because usually they don't let you lift anything with the arm for 6 weeks. They have you in that sling. So shoulder recovery is, patients don't typically like the shoulder recovery. At least with the knee, you're up, you're moving, you're using it. So I think the shoulder recovery might be worse.
Yeah.
Yeah.
Cause I'm feeling better now with the exercises, shoulder,
Mhm.
everything.
Yeah, but it's the same thing in that, it takes a while. It takes a while. And then once you're on the other side, people are happy, but You know, especially like the first couple of weeks with a knee replacement, you know, patients are, they're sore and, you know, it takes a little bit for it to turn that corner. Any other questions? All right, good. Well, thank you guys so much. I really appreciate you coming. I hope that was helpful.
Flyers.
It's just weird. I'm not here for. Oh, yeah. And also.
Mhm.